everyone. Welcome to our third to last HIV rounds of the series, which I can't believe time has flown. We're really thrilled to have Dr. Monica Gandhi speak with us today on next steps for long-acting ART, navigating unanswered questions. As many of you know, Dr. Monica Gandhi is professor of medicine at UCSF, associate division chief in the Division of HIV, ID, and Global Medicine here, director of the UCSF Center for AIDS Research, medical director of the Ward 86 Clinic, and associate program director of the ID Fellowship. She is been an incredible visionary in leading advances for long-acting ART in adherence challenged populations. And as you know, she is one of a kind and kindly agreed to fill in for a speaker who had had to cancel at the last minute. So we're really thankful she could pull this together for us. And I'm looking forward to an incredible talk with lots of audience response. So get your thumbs ready and sign in to PullEv/HIVGR. Let's welcome Dr. Gandhi. Thank you.
Thank you so much. Actually, I have decided in this talk that I've talked a lot about long-acting ART, and so have we all, but this is going to be the unanswered questions. Where are we in this phase of 2024 that we still have to sort out about long-acting ART? So we're going to talk about long-acting ART data from low and middle income countries and adherence challenged patients. We're going to talk about every 8 weeks versus every 4 weeks. What should we do with Cabro? Risk factors for failures, where have they changed? Which mutations, which subtypes, how much does BMI matter? We're going to talk about pharmacokinetics and trough levels. We're going to talk about nodules, pain, and persistence. What is the viral load cutoff that we're going to use to define success in our and other programs? And looking beyond Cabro as options. So, everyone knows this, so we're not going to go over this data. This was the data that led to approval of long-acting cabotegravir and rilpivirine in the United States and Europe, where is the only places that it's approved. These were FLAIR, ATLAS, and ATLAS 2M, which looked at cabotegravir and rilpivirine every 4 weeks in FLAIR and ATLAS, and every 8 weeks in ATLAS 2M, all in virologically suppressed patients. FLAIR were naive. They all got put on oral regimen to get to virologic suppression, and then they went over to long-acting, and the rates of confirmed virologic failure were low, but there were failures, and there were failures that occurred with NNRTI resistance and INSTI resistance. So low rates of failure, but if you fail hard. So this question is actually for Diane because she wrote the editorial on this. So dolutegravir was approved in the US in 2013. When did the first study from low and middle income countries come out? Of course, it was studied at the same time as in high income countries. Or did that study come out in 2013, 2015, 2017, or 2019? So please vote. Dolutegravir, low and middle income countries. What happens? Okay, so I think this is really interesting that 50% of you said 4 years later, and 33% of you said 2019, which would be a little late for when we had gotten it already in 2013, not the studies, but we had gotten the drug in 2013. But the answer is indeed E. And these were the two studies in the New England Journal. One was called the Advanced Study of dolutegravir in South Africa. One was called the NAMSL Study, which was dolutegravir in Cameroon. And Diane and Dr. Doherty wrote the editorial accompanying these two really important papers looking at dolutegravir for the first time in low and middle income countries. And it mattered. It mattered to study them in different settings. Dolutegravir had been approved 2013 here, and it was really the advanced study that made us start thinking about weight gain on dolutegravir and TAF, especially that combination, and especially in women. There was a change. There's something new that came up by studying it in different settings, and it was important to do that. And so if that was important to do that with dolutegravir, what about cabotegravir and rilpivirine? Because I just told you that it had been studied only up to this date and has been approved as of 2021 only in Western or in European and US settings. So this was the first study that looked at cabotegravir and rilpivirine in low and middle income countries. This was the CARE study. And we only have the 48-week results of this, and we only have this in abstract form from CROI. We don't have the full paper. We don't have the 96 weeks results, but that's how long the study will go out. And this study design was everyone was stable on their antiretroviral therapy. In fact, 90.6% were on TLD because that's first line therapy. And everyone had quite a bit of treatment experience in the past, which I think is important. Again, everyone virologically suppressed and switched over to either staying on oral ART or long acting every 8 weeks, important number every 8 weeks. And the CARE study, everyone was virologically suppressed. You couldn't do HIV RNA genotyping before switching them over. And anyway, it was a public health approach. And we're trying to use this in resource limited settings, and we're not going to do lots of genotyping. But one thing that did happen is that in this study, they had collected peripheral blood mononuclear cells at the beginning of the study. And at 48 weeks later, after the study, given that primary endpoint, then that's when those genotypes were done, DNA genotyping in archived DNA in these PBMCs. So important things to note from this slide, 20% had BMIs of greater than 30. Mostly, again, lots of exposure. In fact, 74% had prior exposure to first-line regimen before TLD, which is efavirenz, tenofovir, lamivudine. And most people were on TLD. And this is a side note, or maybe it matters, that though in the archived DNA, there was a lot of proclaimed rilpivirine and even cabotegravir resistance, 14 and 16% respectively. We don't know the mutations that they looked at. We don't know what mutations that they would have examined to say that there's that much cabotegravir resistance in archived DNA. It seems very surprising 5 years into TLD rollout. So this was a question about the study. Nonetheless, at 48 weeks, 97% maintained virologic suppression in both arms. There was a really high rate of on-time injections, but Matt and I were in South Africa recently, and we were pointed out that there was quite a bit of incentivization, 400 rands in South Africa to come in for those on-time injections. And that may, of course, have contributed to that really high rate, 97% of on-time. But it was a surprising result. It was a big result. It raised a lot of attention, and we're going to talk about this later in the talk. Now, this is the next question, because this also came out in low and middle income settings, which is what age and weight is cabotegravir and rilpivirine approved for? Is it approved for those over 16 and weight over 50 kilograms? Is it 12 years of age and weight over 35 kilograms? Is it 18 and weight over 50? Or is there no study yet performed in adolescents? So this is right. This is good. That 50% said no study yet performed in adolescents. That would have been true up to Denver in March at CROI. So there is a study that's been performed in adolescents now that I'm going to talk about. And the right answer is actually it's approved not based on this data, but sort of based on PK and theoretical data down to the age of 12 and weights above 35 kilograms, which is true of oral PrEP with TDF-FTC as well. So what was this study that was performed in adolescents? It's called the Impact 2017 or the MOCA study, and this was not a randomized study. This study was performed in 5 countries, 18 sites, extremely treatment experienced population of 144 adolescents. And by I mean treatment experience, 92% had vertical transmission. So there had been a lot of treatment experience in these patients past. There was no genotyping done. They were all virologically suppressed on whatever they were done on. And then they switched over, not randomized, 144 to long-acting every 8 weeks cab-ril. And what did this study show? 97% maintained virologic suppression. There were no confirmed virologic failures. And this was, again, very treatment experienced population and presumably by their degree of vertical transmission. And also they were smaller than adults. So the body mass index was 19.5 median. And did that matter? it may have mattered. This wasn't made much of, but the pharmacokinetics showed that over time, the troughs actually seem to increase in these adolescents with several doses. And so we have to watch that. It was billed as no changes in pharmacokinetics from adults and adolescents, and I don't think that's quite true. Okay, so if we just went over the data in low and middle income countries, both in abstract form so far, what do we know about those with adherence challenges? Because this is why long acting, at least, had been developed with contraceptives. Certainly, when we got long acting contraceptives, the rates, at least in adolescent girls and young women, of unwanted pregnancies went down. It's definitely helpful in those who are treating psychosis disorders. And Sublocade is, we're going to hear a lot more from Aisha about how that's coming for substance use disorder treatment, long acting as opposed to short acting medications. So this is the next question. Has there been a randomized controlled clinical trial examining long-acting ART among those with viremia? So the answer is yes. 5359 study, kind of. 5359, trick question. It wasn't viremia. 5359, no, but it was adherence challenge, and that should be enough. And then no, but adherence challenge population, 5359, and the FDA wants another randomized trial. So please vote. So this is good. This is great. Because I think this is a particular group of treaters that seems to be convinced that we have a lot of data in those with adherence challenges, and this group is done. And so am I. But the FDA isn't done. So the right answer is actually the FDA does want another randomized trial. In those with viremia, we'll see if I mean, well, it's being launched. So, I think the right answer is D, but E is what is happening in reality. So what do we mean by the 5359 study and viremia versus adherence challenged? This study was actually developed prior to acabitagrelin and rilpivirine being released. And so because of that, there wasn't a study design to say that you take adherence challenged patients without virologic suppression and put them right on long-acting ART. That was not the design. The design was to first get them suppressed in step 1 of the study, with whatever you could do, including quite a bit of conditional economic incentives on oral ART, and then switch over to long-acting ART in step 2 of the study at 24 weeks. And that was at the randomized phase of the study. And the primary endpoint was virologic failure, but look at what we know about the demographics. We're going to find out more at the ECTG meeting in about 3 weeks about substance use in this cohort. All we know is that 14% had current or previous injection drug use. We really need to know more about housing status, about substance use, about mental health, because we didn't have a lot of that yet, and that will come in a couple of weeks. But we did know that prior to randomization, despite the study design, 17% of participants in the long-acting arm were still viremic, because it's hard to get people suppressed on oral ART if by definition you have problems with taking oral ART. And the study was, or at least the DSMB met on February 12, 2024, and they said, let's stop the study and let's actually offer everyone in the oral ART arm, long-acting ART, because there was actually superiority in terms of virologic failure in those who, meaning lower rates of virologic failure in those who got randomized to long-acting ART versus stayed on oral ART, 7% versus 25.4% respectively. And it was that number, that superiority, that got the trial to stop, that got these results out. And maybe for some could have been enough for moving on and saying that this is obviously a strategy that works well in adherence challenge patients. We've talked about this a lot in this room, so I'll only do this for a minute. We have already been using it at Ward 86 in long-acting ART and adherence challenge patients from 2021 onwards. We absolutely knew the inclusion criteria of the trials, but Jan just walked in and we knew that essentially we wanted to try it in anyone who said that they could come in to clinic every 4 weeks, despite that work that would take from Jana and others. And so our results first were published last July in the Annals. And so I'm just going to give you the results of the updated analysis that Matt Hickey presented at CROI. And this was specifically, if we have 286 people in our program, this particular analysis was specifically those who started with viremia and had 48 weeks of data. So it was kind of a limited group. It was 59 individuals. They had a lot of homelessness, 52%, 61% were using stimulants in this small group. And of those 59 participants, 93% over 48 weeks maintained that virologic suppression rate of less than 50 and 95% less than 200. Over the entire cohort, 286 people, there were 3 virologic failures with INSTI and or NNRTI resistance. So that's our final results of our viremic individuals. Has anyone else been doing this? Yes, people have been doing this around the country. The OPERA cohort is an EMR-based database that represents about 14% of people living with HIV in this country. And this was, again, only an abstract form at ID Week in October in Boston, that 176 people in OPERA had been started on long-acting Cabril with a viral load of greater than 50, and 82% at 6 months had suppressed less than 50, and 94% had suppressed less than 200 copies per mil. That 50 versus 200 is going to come up later in this talk. And then finally, a really tiny study from the University of Mississippi, 12 people, tried really hard to get them on oral ART, could not. So put them on long-acting ART, and all 12 suppressed, at least over the short period of time of this study. So it was these particular data points that I just went over. It was the Ward 86 study. It was that little 12-person University of Mississippi study. It was the OPERA cohort. And it was just the press release from NIAID of 5359 that led, prior to CROI, the IAS USA guidelines to change. And what they said is exactly what we're doing here, that we should use long-acting ART in those with viremia and those who have adherence challenges, because if not, they are most at risk for immunosuppression, for OIs, for getting ill. And that's the reason to use it in that patient population. And a modeling study showed that it is that patient population who has low CD4 cell counts that stand to benefit the most. IAS USA has changed. DHHS has remained silent. FDA wants another randomized trial. And that's where we stand with the rollout of long-acting ART in adherence challenge populations. Okay, let's turn to the next unanswered question. What should we do, 8 weeks or 4 weeks? This has a lot to do with Janet and Jan. So let me explain why we started out doing something really hard at Ward 86. So I just really need to remind us is that somehow in the world, almost every other country but here can only get long-acting ART every 8 weeks at 600 milligrams, 900 milligrams Cabril, respectively. That is the UK, Ireland, Europe, Canada, Australia. When it's eventually put on the WHO guidelines, it's going to be every 8 weeks. We have the advantage of this every 4 weeks, and 5359 used every 4 weeks. But all of the real world studies that are being conducted around the world in those who are virologic suppressed, because I just went over the very tiny group that's looking at it in viremics, are using every 8 weeks Cabril. So we're now 3 years into this. Is there a reason to switch to every 8 weeks? Well, this is data from Jan, and 261 people, by the time we got to that number in our clinic, we had, between that and our hormone injections and those who needed substance use, long-acting and antipsychotics, we are giving out 20 injections per day up on the treatment room at Ward 86, and 4,000, more than 4,500 injections a year. This is what's going on at Ward 86. Every month that we've been using this program, we've been giving out more and more injections. That is so much work. And so my question is, what do you think we should do in terms of frequency of injections at Ward 86? Should we administer it every 8 weeks, no matter what, viremic or virologically suppressed? Should we give it every 8 weeks for those with virologic suppression, but every 4 weeks for those with viremia? Should we administer it every 4 weeks for everyone and then go to 8 weeks for maintenance? Or should we give Jake, Des, and Joaquin a medal, because that is a lot of injections, and it is these 3 individuals who've been doing it. So what do you think what we should do? Because we could change. In fact, we could even change this week in what we've decided to do. So this is a group that is very much in sync with what we decided to do this week. And we just changed our protocol this week that we're going to administer it every 8 weeks for those with virologic suppression, but we don't totally feel yet ready to go to every 8 weeks for those with viremia. And we're still going to keep that those with viremia, giving them every 8 weeks. The minute they're virologically suppressed, we can change to every 8 weeks, or we can even tell them, just take your drugs for 3 weeks if you want. And if you're virologically suppressed, I'll let you do every 8 weeks. So that is our protocol. So we just put this up on the Getting to Zero website 2 days ago. And we have changed something major. And in our protocol, we are saying that it's going to be every 8 weeks for almost everyone who's virologically suppressed. And we hope that that will make our injection rates easier. A lot of this is logistic, practical, and following what the rest of the world is doing. Okay, next unanswered question. What has been refined as we've gone through some of this data in terms of the risk factors for failures on cabotegravir and rilpivirine? What mutations matter? What does BMI really mean? And which subtypes can you not use these agents in? So I will start with saying that the multivariate analysis that looked at FLAIR, ATLAS, and ATLAS-2M and the failures in those 3 studies that was first shown in AIDS and then an updated analysis in CID showed that there were 3 risk factors for not doing well on CAB-RIL, these low rates of failure. One was having resistance to rilpivirine, of course. That makes sense, 2 or more, but it was in proviral DNA genotyping. That's interesting because that's not what came out in CARES. The second is having HIV subtype A1 and A6, and the third was having a high BMI. So I will ask you this. What do you think we should do at Ward 86 in terms of pre-existing CAB-RIL mutations? Should we be super strict? The consequences of virologic failure are very high. You could get resistance. So any CAB-RIL mutation in Stanford, do not use it if you've had that in your past. Second is we've had 3 virologic failures with resistance out of 286 at Ward 86. That's low. Let's keep strict, but let's only keep with clinically significant mutations that emerged in vivo. Or number 3, this program is saving lives. CARE showed all this maybe resistance in the reservoir. Doesn't matter. Anything goes. So no one wants to be super strict. That's really interesting because I just wrote Paul Sachs yesterday in preparation for this talk, and they will not allow anyone at the Brigham, anyone in his guidelines and his blogs with even a whiff of a mutation. So that would have been A, but I guess you're listening to us, and most of you said B, and that's what we decided to go with. So there, how do we define clinically significant mutations? We don't actually think that mutations that are defined in vitro via serial passage as reducing susceptibility to ARVs are as clinically significant as mutations that come out during breakthrough infections. If you are in a trial and you get virologic failure on a regimen, what mutations come out when you get virologic failure? And it is those mutations that we've decided to think about, and the CARE study made us think about this because maybe having an old long time ago V179D doesn't matter. And so these are the 3 groups of individuals that we decided to use to define our mutational patterns. HPTN 083 breakthroughs, that was cabotegravir every 8 weeks for prevention. This is a study in April of an AAC of 2023, and these bolded mutations were the ones that came out as clinically significant if you actually broke through cabotegravir and got an infection. Second is the mutations that came out in the ECHO and THRIVE trials. These were the trials that looked at rilpivirine versus efavirenz in treatment-naive individuals. These were the mutations that came out if you failed with rilpivirine, and we count those mutations. And the third group is that handful of failures in ATLAS, ATLAS-2M, and FLAIR. They emerged cabotegravir or rilpivirine resistance, and we collected those. Thank you to Kate Koss and Urvi Parikh, which really combed through the data to get this. We collected those mutations, and it is those mutations that we don't let in. So if you've had any of these mutations, and now this is what our protocol looks like up on the Getting to Zero website, If you have any of those mutations that came out in those three groups, if you've had any history of that in your viral genotype, not in your DNA archived genotype, which we discourage doing at Ward 86, then we do not let you be started on cabotegravir and rilpivirine. Clinically significant mutations, that's how we've decided to define them. Oh, and importantly, when I was talking to Diane about this, we looked at our 3 virologic failures who came out in our 286 individuals with mutations, and they all had mutations in these categories. Okay, third question, high BMI. We use longer needles. I've shown this before. This is a British Journal of Clinical Pharmacology study that said that if you used a longer needle, it's likely to get into the intramuscular space if you have a high BMI of greater than 30, and maybe they'll spread out more. And certainly in that study, there were higher cabotegravir concentrations. But I do want to remind us that CARES, 20% of people had virologic, had BMIs of greater than 30, and they certainly didn't use longer needles. So I just want us to think about that. And I don't know if we need longer needles. We're going to do it still at Ward 86 because we're lucky enough to be able to get them, but I'm not sure how strongly I feel about it after this data. And then finally, what cabotegravir should not be used in those with the following HIV subtypes. And let's answer this. Is it HIV subtype B? Is it HIV subtypes A1 and 6? Is it C? Is it HIV subtype A1 or HIV subtype A6? So please answer. Great. Okay. This is really interesting because you had all heard the multivariate model that I presented from the FLAIR Atlas Alice 2M failures, and A1, A6 were both identified as resulting in failure. So you all, many of you answered B, but actually that's not true anymore. And I think that we can put A1 to rest. And why can we put A1 to rest? Because in the CARE study, if you look down at the number of viral genotypes, viral subtypes, over 55% were subtype A1. And so, and everyone did great in CARES, right? At least at 48 weeks. So A1's pretty much out. There were discussion at the meeting that everyone didn't care about A1 anymore. And I think this is good enough data to show that. And actually A1 and A6 really differ from one another. A6 is mainly found in Eastern Europe. And so I think I would eliminate A6. We don't see it here, but I will say that there are physicians in Poland who've taken a number of Ukrainian refugees who are still using it in those with A6. So let's see when they put out real world data, if that's really going to be clinically significant. Okay, next unanswered question. What about pharmacokinetics with the long-acting ART, and how much do they matter? Well, I think this is a really important question because we do not monitor drug levels in antiretroviral therapy. We monitor drug levels for efficacy with vancomycin. We think about gentamicin levels. In terms of toxicities, there are very few instances in infectious disease where we're actually using drug levels to monitor therapy. And the reason that that has come out with oral ART is though there are individual differences in pharmacokinetics, definitely. In fact, women probably have higher PI levels than men, for example, which can lead to reduced tolerability. It hasn't been a principle or a practice to do therapeutic drug monitoring in antiretroviral therapy. But maybe this would matter in long-acting ART. So I think this is a really important study that came out of the Lancet Regional Health Europe 2 months ago. So surprisingly little is known actually about the PK of long-acting ART in real-world populations. We do know with other depot drugs that it matters. Your injection technique matters, whether you get into the right space, sub-Q, subdermal, intramuscular, it matters if you get into the right space. So your technique matters. And so what was this study? This was published in Lancet, and it was a Swiss HIV cohort study of 725 PK samples, rilpivirine and cabotegravir concentrations were done. in 186 people living with HIV from March 2022 to March 2023. And you could see here on the left panel that those is the inter-individual variability with oral CAB and RIL. And then here's the inter-individual variability with intramuscularly administered CAB and RIL. These are trough concentrations. What you should really note is the degree of inter-individual variability, the span. Some people have really high levels. Some people actually had very persistently low levels. That is something about their individual ability to absorb and distribute and eliminate and metabolize these drugs. So there were, in general, lower cabotegravir troughs in men than women, which I'll talk about in the next slide. And interestingly, and I think importantly, almost everyone remains suppressed. This is every 8 weeks, because that's what's available in Europe. And there were 3 in this sample who had virologic failure, and 2 out of those 3 had low levels. So hard to tell if 2/3 of only 3 people having low levels means that low levels is the only way that we could predict virologic failure. I don't know. There was also no association between low trough levels and detectable HIV viral load. So I think this is an important study. It's the biggest study that we have of essentially trough concentrations in real world populations with Q8-week CAB-RIL. But what else do we know? Well, even before the studies were complete for the phase 3 trials of long-acting CAB-RIL, we already knew that there was something different between men and women. And the difference is twofold. One is that the pharmacokinetic tail of cabotegravir in women is much longer than it is in men. This is represented by the red lines here. And so what does that mean? I don't know what that means, because that would probably imply that maybe you could have more failure if you stopped the drug and you had longer selective drug pressure if you weren't taking another form of PrEP. But what does it mean in terms of, for example, toxicities? What does it mean in terms of success? One thing that we do know that in the HPTN 084 study, which was the study that showed superiority of long-acting cabotegravir every 8 weeks in cisgender women, there was 2 really important things that came out of that study that was different from HPTN 083. One is that there was a lot of PK forgiveness. You're supposed to come at 8 weeks, but women came at 12 weeks, even 16 weeks, and the PK was still really high. In fact, above supposedly the protective PA IC90 for protection, even at 16 weeks, even if you doubled the time that you were supposed to come in. So that was data from HPTN 084. The other important difference is that in HPTN 083, there were 34 failures. 18 of those failed with resistance. There were only 6 failures in HPTN 084 and not a single failed with resistance. So somehow there was higher superiority for protective efficacy with cabotegravir in HPTN 084, 89% above TDF FTC versus 66% superiority in men and transgender women. What does that mean? I think drug levels matter, and I think women have higher drug levels than men. And then finally, has there been any study that says, okay, what matters is drug levels? BMI, I don't know, because it matters where you put the drug in. Age, I don't know. I don't know about race, ethnicity. Maybe it's just, you just need to monitor drug levels. And this group, at least in the Netherlands, is making a case for that. In fact, in this particular center in Amsterdam, they will not administer long-acting cabotegravir and rilpivirine without doing therapeutic drug monitoring at troughs. And why are they doing that? This is a tiny study. This was published in CID, but it was 5 cases of virologic failure on long-acting CAB-RIL. And of those 5 cases, at some point in their trough monitoring, they had either low cabotegravir levels, low rilpivirine levels, or both. And all 5 of those failed with resistance. And they had some explanation for the low drug levels in some. It was just 5 people, but somehow this merited a CID paper. And I think at least I'll tell you that this group is launching a much bigger study to really look at therapeutic drug monitoring of CAB-RIL, and have decided in clinical practice not to give it out with this. And if you have a low level, they'll take you off the drug. So I think the bottom line is that we do need larger population PK models to define the risk factors for failure, but also to define the risk factors for low levels. Population PK models are limited. They're restricted to what I just told you. And I do think the SPLASH cohort is a perfect place with now 290 people on it to do cabotegravir and rilpivirine trough concentrations. And hopefully we'll be able to do that in the next year. Okay, next unanswered questions. What about nodules? Oh yeah, please.
Can you remind us the available genotypes and risk factors for failure in the 3 people that failed at Ward 86?
The 3 people that failed at Ward 86 genotypes and failures, they actually all had, 2 of them had preceding mutations that would have been in our group of mutations that we defined. So we defined these are our mutations that we don't allow in. And one of them had a T97A, which we have put in our list of mutations that we're not going to allow for cabotegravir. And one had a V179I. One also had a drug-drug interaction that would have led to lower cabotegravir concentration. So we had some real risk factors for failure and for low levels, just like these 5 individuals also had in this Amsterdam study also had risk factors for having lower levels in 3 individuals. Okay, so what about nodules and, oh yeah. Oh yeah, please.
Treatment failure in viremic patients starting ART. I know the numbers are relatively small, but compared to suppressed patients starting ART, such as pre-treatment viral load, for example. Just curious if you
yeah, it's such a good question, and that those analyses need to be done. We've only actually looked at those who are viremic and their virologic outcomes at 48 weeks. And now our next study in SPLASH is to compare those who started with virologic suppression and those with viremia. But importantly, the 3 failures did occur in those with viremia, who started with viremia. And yes, in terms of their viral loads, there wasn't a specific, like they weren't all over 100,000. One was. So I don't know if we know. And if we looked across our entire cohort, we're kind of where this is, meaning our confirmed virologic failure rate, is similar to where in Atlas 2M, if you looked across the entire cohort, and that's even including, not 50%, but about 30% being actually less than that, like 28% being viremic. So we still think we're coming out where we should be in terms of confirmed virologic failure, but what we really want to do is studies with drug levels, putting into our equations to figure out all the risk factors for failure with levels. Okay, so nodules, pain, persistence. I think there's pain with these injections, and it's not just it's actually not just lenacapavir, it's also with cabotegravir and rilpivirine. So my question to you is, what percentage of patients at Ward 86 started on long-acting ART, discontinued? I told you about 290 people are now on a long-acting ART, but how many people actually started it and then stopped? Now, this could be for different reasons. One of them could be pain. Was it 0? Everyone who started has stayed on long-acting ART. Is it 10% stopped? Is it 15% stopped? Is it 19% stopped? Or 24% of people that we started stopped? So no one thinks it's 0, but right now there's a division between 10% or 15% that stopped. And no one actually said 24%. but that's the right answer. So this is just new data. I mean, we've been trying to really tease out how many people started and then stopped. And it isn't just because of pain. In fact, I don't know how many people had pain because we have to really go through and figure that out. It's just that 359 people started on long-acting ART at Ward 86. And right now, at least of this last analysis, 274 are on long-acting ART. And there were lots of reasons. 10 actually passed away. We couldn't find them in 26 people. And actually of those 85, that's 46 went back to oral ART and in fact seemed to be able to adhere better to oral ART after trying that foray into long-acting ART. So this happens. This may be pain. We're going to sort this out. This is some of the data that we want to put out from our cohort, but not everyone loves injections. And with lenacapavir specifically, and we're going to talk about lenacapavir later, there is about a 20%, well, there's more pain. Okay, I'll just say there's a 26% nodule rate, at least in the Capella study, which we'll talk about later. And nodules in 26% maybe is just essentially the depot formulation under the skin putting out the product. So maybe that's just a feature. And maybe it doesn't bother people. And also the drug company seems to be changing the route of administration quite quickly on us and just put out a something last week that maybe we need to go in at 90 degrees and put it in more to the intradermal, below dermal space as opposed to sub-Q. And I think it'd be nice to sort out exactly, these kind of phrases of subcutaneous versus subdermal. So maybe there'll be ways to make this better, but we are seeing pain and we have seen pain with both the intramuscular injections and the lenacapavir injections at our clinic. Okay, next question. What is the viral load cutoff to define success? This is actually a very philosophical question and it relates to changes in testing capability over time. And I'm going to leave this as a question to all of you. And my question to you is, what do you think Ward 86 should use as the viral load cutoff to define success on long-acting ART? Do you think it should be less than 30, which is the lower limits of quantification of our assay in our laboratory? Should it be less than 50, which is really used in a lot of clinical trials? Should it be less than 200? Should it be less than 500? Or should we go WHO style and should it be less than 1,000? Okay, so this is so interesting. So what I think is really interesting is that no one has actually said less than 30, which is the lower limits of quantification of our assay, which is what we use for oral ART. If I saw someone with 51, 63, probably wouldn't switch, but that isn't the lower limit of quantification of the assay. I think it's very interesting that some of you said less than 500, and we'll talk about that. And then some said less than 200. We have decided on C, and I'm going to explain why. So what is this magical number? What does 200 mean? One thing before I get to the public health implications is I really want to refer you to this really nice article in OFID last year, which I really liked. As you know, the definition of an undetectable viral load has evolved over the years with advances in testing. It used to be 500. It used to be then 200. Now it's 30. Some centers it's less than 20. It depends on your PCR LLOQ. And this particular opinion piece really had a lot of nice references that persistent HIV RNA levels of greater than 200 but less than 500 is that point at which you can get viral evolution and accumulation of drug resistance. But HIV RNA levels of less than 200 are not clearly associated with any negative clinical outcomes, at least in terms of CD4 cell count progression and, for example, cardiovascular outcomes. And there's not good data that you're evolving you have viral evolution between 50 and 200. And indeed, none of our patients that we've seen, and I'll talk about blips in a minute, have had resistance emerge when they were sitting in that 130 blip point, for example. And so the CDC actually uses less than 200 as their definition of virologic success. When they present data that 66% of people in this country are virologically suppressed and 89% at Ryan White care clinics, it's a 200 cutoff. And there was really nice data at CROI about why 200, I think, is the number. There's another reason that we were thinking about 200, and that is really the undetectable equals untransmittable data. Remember that in terms of public health implications, these three big cohort studies, Partner, Opposites Attract, and Partner 2, were the three studies where there were serodiscordant couples, either same-sex, heterosexual, lots of condomless sex acts, and the transmissions within those partnerships were 0, 0, 0. The person who presented this at the International AIDS meeting, when she presented this data, actually broke down crying, because it was such an important moment to show that undetectable, less than 200 is truly truly untransmittable. Now, what about viral loads of less than 1,000? The World Health Organization, when they presented at IAS 2023 in Australia, were not met with the same enthusiasm when they put out a systematic review meta-analysis in Lancet saying, let's use a less than 1,000 as our undetectable equals untransmittable cut point. The reason they weren't met with that enthusiasm is that there's very little data between 200 and 1,000 of viral transmission to others. And I don't think the 1,000 should be the cut point for the individual themselves based on what we just talked about. And I don't think it should be the cut point for U equals U, but that's at the moment what's happening. So I think 200 is the number for a variety of reasons. And what have we seen at Word 86? We have seen blips. We have actually seen more blips on long-acting ART than we do with oral ART. We have been recording them. We've been watching them. We've been following them closely. And we don't see clinical consequences if it's less than 200. And so we made, I think, kind of a bold decision just yesterday. And in our new guidelines that we put up on the website, we have decided to use less than 200 copies per mil as our cut point for those on long-acting ART. Again, sort of based on our own clinical experience and based philosophically on what we think is a clinically meaningful virologic suppression rate. That's where we are. Absolutely, we'll follow this and we'll think about it closely. Okay, and then I want to end with beyond cabotegravir and rilpivirine as options and then leave time for questions. So the only other option that we have out there is lenacapavir. There's no other drug that's approved yet for long-acting ART, but this was approved on December 12, 2022, and this is a first-in-class capsid inhibitor, and it's so potent that you can actually give it every 26 weeks as an injection of 927 milligrams after 2 oral loading doses. So the Capella study was a single-arm study because it's a rare phenotype to have multi-drug resistant HIV, and that was the group that the study was performed in. And, you know, it absolutely, lenacapavir being added to whatever you can get in terms of oral background regimen did lead to higher rates of virologic suppression in this small group of 72 individuals. And it was this 26-week data in the New England Journal that led to FDA approval of lenacapavir. But we now have 104-week data. And I think that changed my mind somewhat at CROI to see this poster, because there's only 72 people in Capella. I mean, everyone sort of knew them really well. And at the 52-week data point that was presented and published in Lancet HIV, 14 out of 72 experienced virologic failure. That was distressing. That is a very high rate of virologic failure. And all 14 had some mutation that they said was associated with lenacapavir. But with a lot of counseling and telling people, please take your oral ART, at least the background, actually, it was only 2 out of 72 who were failing by 104 weeks. And so those 12 resuppressed. Maybe we don't know really what the lenacapavir associated mutations are. Maybe we need to change that definition. And at any rate, 70 over 72 in such a multi-drug resistant HIV population was really quite successful. So I'm wondering what the real genetic barrier to lenacapavir is, and I think we need more data on that. And then one other possible option that will come out later is an NRTTI, nucleoside reverse translocation transcription inhibitor, which is islatravir. It is first in class as well. It is not out yet. There's only a phase 2 study of looking at islatravir with lenacapavir given once weekly, both as oral doses. And those doses were adjusted because islatravir at a higher dose led to decreased white blood cell counts and decreased CD4 cell counts. So at the adjusted doses, at least in this phase 2 study, people stayed virologically suppressed if they went over from either staying on oral ART, big TAF FTC, to islatravir, lenacapavir every once a week. And maybe some people will like once a week, and we do need the phase 3 data for this. I won't go over a summary because I really went over this, but this is a reference slide for you on the trials in naive and suppressed people on Cabril, those with adherence challenges, and then those with lenacapavir, which also includes the Calibrate study and the Artistry study, which is using lenacapavir, bictegravir in a phase 2 study once daily as a single pill. Okay, so what about one other option? What about if we can mix and match these drugs? Because if we can get them on insurance, then there are 3 long-acting ART agents out there, cabotegravir, rilpivirine, and lenacapavir. So people have been doing that. In fact, this is a case series of individuals across 4 academic medical centers where the doctors or the pharmacists just decided, you know what, I want to get lenacapavir. These patient has NNRTI resistance. I can't use rilpivirine, and I want to combine lenacapavir with cabotegravir. And it's just a case series. People did well. They increased their virologic suppression rate if you used lenacapavir, but we need a trial. And after a lot of advocacy, we are getting a trial, but it's tiny. So these 2 pharmaceutical companies, which make lenacapavir and cabotegravir, to put it nicely, have not ever worked together before. But they have really, after a lot of advocacy, kindly agreed to let us do a tiny trial. It's in the ACTG. It's only going to be 30 people. And these participants will all have NNRTI resistance. They'll all have viremia, and they'll all have challenges to taking oral ART. But what I'm hoping is that this small ACTG study will open up a larger trial, to open the door for a larger trial in low and middle income countries, because that's actually where it's needed. Right now in low and middle income countries, the rate of resistance to rilpivirine is up to 16% in some countries. The one thing about NNRTI resistance mutations is, even though we switched over to TLD 5 years ago, almost 6 if you count men and women, if you count men, we still have persistent NNRTI resistance circulating. And that's likely because NNRTI resistance is transmitted. It's not going away. And if we're going to have NNRTI resistance, then the option for having lenacapavir and cabotegravir as the 2 agents get put together for those with rilpivirine resistance is very appealing. So I hope, again, that this small study will open up the door to a larger study. I think that would be the right thing to do. Okay, and I will end there and take your questions. Thank you so much.
Thank you so much, Monica. I'm going to pop around with this microphone and see if there are questions.
Thanks for a great talk, Monica.
Thank you.
2 questions. One is, why do you think first of all, the blips at word 86, I'm just curious. I've had a patient who can't take oral ART, and unlike a definition of blip where you imagine, if you think of a definition of viral suppression after a small increase below 200, he remains in the sort of 50 to 200 range persistently. So I was curious about why we think you're seeing more of those compared to oral ART. And then also just another patient at ward 86 that have who's repeatedly had genotypes that are wild type, very heavily treatment experienced. About a decade ago, and archived, or about 8 years ago, genotype showing just 1 minor rilpivirine mutation. And just thoughts about cab, ril plus len, and someone like that who, again, as in this case, can't take oral ART. Thanks.
Yeah, those are such great questions, because my theory about why we're seeing more blips and more low-level viremia, if you define that as less than 200 on long-acting, is that you don't get a slug of drug every day where you have a high Cmax and the epic battle between virus and host is occurring, because when you get an oral ART every day, you have a really high Cmax. And then, maybe you don't take it the next day and then it doesn't see enough drug. But what happens with long acting is you just see a low decrease, a gradual decrease of PK level over time. And I don't know what's happening at the trough, at that end of the dosing interval, in terms of that fight between virus and and drug. And I think that there's more ability for the virus to blip and keep on going through because it doesn't have that daily Cmax. That's my theory. I don't know yet. And I think we need to do those PK levels. And I think that's going to be a really important study. And then in terms of this minor mutation in the past, when we got lenacapavir in December 2022, we started using it like every time there was a whiff of a mutation, like your patient with rilpivirine mutation a long time ago, we just say, you know what, doesn't matter, let's add on lenacapavir. We have it, we're lucky, we can get it, and we'll do cab, ril, lenacapavir. The CARE study would argue against that, and so would practicality in other settings. And I don't know what we're good. We tend to, because we were doing something that was already going out on a limb, and we really did go out on a limb to start this in viremic patients, we wanted to be more conservative about people who had even low-level mutations. And we did use len, and we have used len, but I don't know if it's necessary. And I do think that we need the CARE study. We need the 96-week data really badly. And I don't know if that's going to be at IAS, but I think it's important to say if you have all that archived rilpivirine resistance, forget about the cab, I don't actually believe it, but if you have that much rilpivirine resistance, are you going to break through from 48 to 96 weeks? I don't know. I think that's really important to see. And then if you don't, what does archived mean versus viral genotype? What does on-time injections mean? You know, I just see there's lots of remaining questions, but so I don't know what I would do with that person, but I'd be more likely after CARES to peel off the len.
Couple of questions from the chat. One is from Michael Peluso. Long-acting ARTs is a challenge for HIV cure studies that involve treatment interruption to see if people rebound, when that's occurring, and when we can alter the set point. And given injectables last much longer, how long do you think you need to wait to be confident that the tail is gone? A year, 2 years? Only if drug levels are consistent with this. There was a long discussion at ATI consensus meeting, but no consensus.
Yeah, that's such a good question because ATIs, if you're really going to treatment interrupt, you really need to do that in a cure study, and you need to make sure that there's not drug on board. In fact, we're doing urine tenofovir levels in people in one cure study in ACTG because people still take their drug. And so if you really looked at this data, and this was combined data from the latte studies, and the latte studies were the phase 2 trials that led up to the phase 3, you would actually have to wait all the way out 228 days in some women. I mean, meaning that's how long the drug can still be in your system. And I think it depends on the inter-individual PK variability of someone, how long the drug is going to still be in your system, and also what's a clinically meaningful drug level in terms of being able to affect the reservoir versus not. So I would advise that people do drug levels, and then do we know the true clinically meaningful level? No, I don't actually think we've properly defined troughs. What's really, I think, important in this study is that real world study that I showed you from the Swiss cohort study, a lot of people had below trough levels and they still did fine. So I don't know if we really know what a clinically meaningful level is with long acting. So I think a lot more to be done.
Thank you. One other question from the chat from Vic Jean. Wonderful talk. Has the Brigham had more failures with minor NNRTI mutations, whereas we haven't? I wonder if this is the case, whether it may be due to our strong wraparound multifactorial implementation structure. Would love your thoughts on that.
I don't think the Brigham has not presented their data on how they've done. It's just what happened is someone wrote me from the University of Washington and Paul Sachs at the same time and said, what are you doing? And I said, we're only using these mutations. And Paul Sachs said, we're not going to let anyone in with even any mutations. So they have not presented data from their center. They don't actually have a lot of people on long-acting ART, but Paul Sachs has been really a champion for using it in those with viremia. He's the one who wrote the JAMA piece summarizing the IAS USA guidelines. But he also, whatever he writes, there's a lot of caveats and there's a lot of concern about minor mutations. And I think it's, again, only data from a center like ours that can answer those questions.
Yet to be seen. A lot of congratulations and thanks to staff at Ward 86 for the program. Let's close there. Thank you so much, Dr. Gandhi.
Look at all those injections that they do. Okay, thank you very much.